Hello and welcome to Dementia UK's Summer School 2025. My name's Laura Birch. I work as an Admiral nurse at EHS NHS Trust based at Macclesfield Hospital, so I'm an acute care Admiral nurse. I'm here today to talk to you about pain management in dementia care. So this is an area I'm extremely passionate about and I hope you enjoy the session. Any questions, I'm more than happy to take them at the end. So the objectives of today are to understand pain and why it occurs, to understand changes in behaviour and how this can be an indicator for pain. We're going to be able to consider pain assessment tools that are used in dementia care, and we're also going to understand pain management, including pharmacological and non-pharmacological interventions. So I want you just to take a moment to imagine you're at work, it's really noisy, there's building work going on outside, you've developed a migraine, and two people are talking to you, trying to gain all of your attention. I just want you to think about how this would make you feel, just for a moment. So for me, the main words that come to me are irritable, frustrated, tired, in pain. But obviously the behaviour that we show for this are going to be irritability. It's going to show that we are changing emotionally, that people are going to be irritable, frustrated, tired, and it's no different in dementia care. People with dementia can't always tell us what they're feeling. So that could be that they're in pain, that they're frustrated, that they're hungry. With pain, sometimes they won't tell us. I've even had patients that would say no when I ask them if they're in pain, but it's very evident that they are. So we need to be the detectives, and we're going to go through what we call the Columbo approach by Ian James today, because we really do need to do a bit of a detective, a bit of a Columbo, working out what that person is trying to tell us. So, obviously we need to recognise the issue. In the community, more than half of patients with dementia will experience daily pain. I know from speaking with many professionals that they at least recommend regular paracetamol to anyone over a certain age because, naturally our bones are going to creak more, we're going to be a bit more tired, more likely to have a long-term condition that indicates pain. In nursing homes, around 60 to 80% of people with dementia experience regular pain, and approximately 1 in 3 residents have moderate to severe pain, and patients with more severe dementia experience more pain than those with less severe dementia. And I suppose the reason for that is because of the lack of communication, the inability to let staff know that they need pain relief or understand what they can do to support their pain. So, what is pain? This is a standard definition, but I suppose there's lots of ways that we could define it. It's an unpleasant sensory and emotional experience that's often associated or resembling that or actual potential tissue damage. So pain is a personal experience. It can obviously vary in degree of biological and psychological and social factors. So everyone's going to have a different experience of pain. And that doesn't mean just physical pain. It can be the emotional damage that might do, the mental health repercussions that may have, the social isolation that person may have as a result of not being able to mobilise and socialise the way that they used to. So again, there's different aspects, things to consider there. So when we look at what causes pain, there's lots of different things that could cause pain for a person with dementia. So things such as health conditions. So the majority of our patients who come into hospital have things such as osteoporosis, arthritis, previous hip issues. So looking at previous injuries. So for example, a previous fractured hip might lead to long-term pain after that. Obviously previous leg injuries, any falls that they maybe had. Obviously, things such as constipation can even lead to pain. So thinking about someone with dementia, if they haven't opened their bowels regularly, they may have more pain out in their stomach, and they might not be able to verbalise that, which could lead to some long-term behaviours. Things such as urinary tract infections. So I've had patients that have had recurring urinary tract infections, and that's when we see things such as delirium start to present as well. Mouth problems. So have they seen a dental practitioner recently? Have they got any sores in their mouth? Have they got any other conditions in their mouth or dental hygiene? They're all things we need to consider. And inactivity, so leaving us more deconditioned, is more likely to increase our pain levels. So there are 4 key types of pain that we tend to see. Again, the list is longer than that, but these are the key ones that we tend to see in a hospital environment. So acute pain, this refers to a short-term kind of pain. So that's typically up to 3 months. So for example, if somebody is coming to hospital with a fall and has sustained a fractured hip, this may be considered a short-term acute pain, unless, of course, the pain then continues after the 3-month period, which then moves to a chronic pain. So a chronic pain tends to be a longer-term pain, so over a 3-month period. So this could be things such as arthritis, osteoporosis. Again, things such as dental pain, I suppose, if it was to last longer than that. Neuropathic pain, so again, this leads to things such as nerve damage, where your nervous system has sustained dysfunction or damage. So again, people often get nerve pain down their back and their legs. So again, it's being mindful of how we target nerve pain, because then the medication may be slightly different to that of an acute pain. Nociceptive pain again refers to tissue injuries, so people with wounds, for example. If they sustained a fall and damaged a part of their body, the tissue damage would then cause nociceptive pain. So here are some of the effects of pain then. So obviously everyone's going to be affected differently, but these are some to consider when it comes to looking after people with dementia. So increased care needs. So for example, if somebody has pain in their back, they're more likely to rely on you physically. This could lead to them being more likely to remain in bed because they feel that this is where their comfort remains. It could lead to them not being able to provide their own personal hygiene. This itself could lead to deconditioning over time as well, and their lack of independence could then reduce the stimulation that they're getting as well, which can therefore reduce cognitive functioning as well. It could lead to restlessness. So, for example, if somebody's in pain, they may be in bed, they may be more awake at night, they may be tossing and turning. This could lead to us suspecting that maybe that person is uncomfortable. Agitation. So as I said before, this is their way of voicing and communicating that to you. So I always start my assessments by double checking, does that person have any reason why they may be in pain? And have we at least tried to remove some of that pain, if it be through regular paracetamol? Is there anything that's changing as a result of that? Mood fluctuations. So I know that we said a bit about, people's mood may be up and down. Distress. So that doesn't just come in the form of agitation. It can come in the form of teariness, being withdrawn, apathetic. They're all things we need to be mindful of. If someone withdraws, what is the reason for that? Anxiety and or depression. So again, feelings of helplessness, more likely to experience pain, to feel socially isolated from their loved ones and their friends, and not being involved in things can lead to that long-term mental health. Isolation. So as I've said before, if someone's in pain, they may no longer go out as much or be as active as they used to be, which may reduce their social networks, which itself can lead to that mental health decline. Fear. So again, they may not know what to do. They might feel hopeless. They might not know where to turn. It could be that they're fearful of falling, which for those of us who know about falls, the more fearful you are of falling, the increased risk you have of falling. So it's a vicious cycle. And then sleeplessness, or what we call sundowning. So people may be awake at night because they are unable to get comfortable, which then leads to them wandering at night, which then reduces that body clock being in sync as well. So, as we said before, we need to be a bit of a detective when it comes to recognising pain. People with dementia may not be able to communicate their pain, so we have different ways of measuring that. In our hospital wards, we often ask people with dementia, are you in pain? Many people with dementia can tell us that, so that's absolutely fine. Someone can self-report they're in pain, but some people may not be able to tell us that. So for an example, I had a lady she'd come in after a fall, she was bedbound, and she'd shout throughout the day. And staff would say that's just her norm because she'd done that in the nursing home. However, there was a slight change in that behaviour that actually indicated she was in pain because it was a little bit louder, she was doing it more regularly. Before it had been at certain times, which was down to a sundowning. This was different. So we had to take the time to understand the differences in that and to be able to make a difference to her comfort levels. So again, understanding that changes in behaviour can be their way of communicating to you, and that's where we really have to do a bit of digging to see what's going on. So this is a really important thing to think about. So I like to think of the term ouch, and this is what we're going to go through separately to make sure you're aware of each area, but it refers to observe, understand, communicate, and help. So when we talk about observation, so this is about knowing your person. Obviously, in a hospital environment, we understand difficulties of knowing the person fully, but we very much rely on families, a life history, collateral history that we can gain from care homes or carers to learn about the person. We need to observe. So this is about spending a little bit of time with that person, recognizing facial expressions, looking at their body language. Has the sounds that they're making changed? Are they shouting more? Is it a little bit different? Is their facial expressions changing? Have they got a grimace look? Are they kind of tightened up and contained in their bed? Are they withdrawn? Is their body language kind of hidden? A lot of people kind of cage themselves and curl themselves up. That's a bit of a guarding behaviour. So again, we need to think if that's something they're doing. We need to look at their mood and their behaviour changes. For example, did you get them out of bed and now they're quite agitated now you've got them out of bed? Now, that could be for a variety of reasons, but it could be that they're now in pain from mobilising. So you just be mindful of that person, spending a bit of the time, and we will refer to some of the pain tools which will help with your observations shortly. So understand. So is this normal for them? We need to stop with the they always shout mentality. So as I said about that lady, she did used to shout in her care home. And there's a lot of reasons why people may shout. They always say it's because they either want attention, so they want you to come and support them. It could be because they want you to go away, so they don't want that confrontation, they don't want the intervention, they want you to step away. And it can also be because they want, they just like the feeling. So some people quite enjoy the feeling, their vocal cords off shouting. But obviously we need to work out which one of those is it. And again, for someone living with dementia, if they're experiencing pain, they may be shouting because of the uncomfortability of it. So we need to be mindful that we need to always examine that behaviour. Even if it's something that's their norm, we need to examine that further to really check that there's no physical or emotional cause that we can meet. So communicate. So again, if you start to have concerns, you've done your pain assessments, which we'll go through shortly, and you start to identify that this person may be in pain, then we need to escalate these concerns. So sharing these with a healthcare professional, a doctor, sharing with pain services if that's what you've got in your area, but the right professionals to really make a difference. So again, sharing those scores. So we're going to go through 2 pain tools shortly. And if they are a high score, maybe identifying what behaviours they're showing. So are they grimacing? Are they guarded? Are they withdrawn? Are they shouting? Identifying those particular behaviours and showing that with a healthcare professional can allow that assessment to take place. So we're going to touch on some of the physical changes we may see in a person when they're in pain. So the first one would be an increased pulse rate. So this is your heart rate. So imagining if you become uncomfortable, your back's starting to hurt in your chair, you're going to get a bit more fidgety, which in itself will increase your heart rate. But obviously if someone's distressed, which we tend to see with pain, someone's heart rate would increase because of this as well. Also be mindful of increased temperature. This might not happen for everybody, but someone with increased temperature may be because they're more stressed, more agitated, which leads to that increase. Increased sweating, so they might be quite clammy, quite distressed. You might start to see them sweat more. That's something just to be mindful of. High blood pressure, so again, when we're in pain, our blood pressure does tend to increase. High respiratory rate, so again, we're breathing heavier. We're trying to get those breathing in to calm ourselves down, which is a natural thing for the body to do. But again, it's something to be mindful of when it comes to pain. And then guarding the area of the body that hurts. So we're very quick to kind of guard the area. So if you've got a tummy ache, you might put your hands on your stomach. If you've got a bad arm, you instantly hold it, don't you? So again, someone with dementia will still present those same behaviours. So emotional changes then, this is not a long list, but again, there's many other symptoms you may see in someone with dementia, but things such as increased agitation and aggression, that's their way of communicating to you that something's wrong, so it's an unmet need. So again, they might be agitated because they don't know what's bothering them. There's something that's really hurting, but they can't quite understand what it is. Reaction to touch, so if they're touching an area and then they're pulling away, that, their guarding behaviour, again, it's something that's causing some distress, some discomfort. Changes in mobilisation. So we're going to go through a case study later on about a gentleman that did start to mobilise less, and again, that had been down to a long-standing hip issue. Again, if they are in pain, they're less likely to use the area of the body. So again, if the leg hurts, they're less likely to mobilise, which over time is going to cause that deconditioning. So we see people go into hospital that maybe had a fall or had an injury. The longer they're here and the less likely they mobilise, the less likely they will regain the same skills as before. So again, we want to really be promoting that where possible. And again, if someone's in pain, they're less likely to be able to rest because they can't get into a comfy position. They're more likely to, moving in the bed, more likely to experience sleeplessness in the nighttime as well, which can lead to that reduced body clock. And again, all these together can cause an increase in cognitive decline of that person. So to mindful of some non-verbal cues then. So as we said before, people with dementia might not tell you they're in pain, but may use non-verbal indicators to let you know that. So things such as changes in facial expressions, so frowning, being quite tearful, hard to distract. So again, that's something I see quite a lot, is trying to distract someone from a particular topic. Again, if they're worried about going somewhere or they keep walking or they don't want to get out of bed, it's being mindful that might be an indicator of pain. Things like grimacing, so their face is quite tense, quite withheld. Again, that's something to be mindful of. And as we said before, guarding type behaviours, so knees up, quite guarded, quite isolated and quite withdrawn, can also be indicators of pain. So now we're going to look at what we can do. So we've talked about all the types of pain we might have, the symptoms, some of the indicators of pain, but this is just to give you a bit of an understanding on what you can do to identify and target someone's pain. So I like just to touch on the Columbo approach. So Ian James developed this approach, and I suppose the idea is pretty much in the title, that we need to be a better detective when it comes to people living with dementia. So they may not be able to tell us what's wrong, but we need to look at all their life history, look at what's currently going on, and actually work out, is there something distressing that person? And again, this works very closely alongside the Newcastle model. So what that means is, as you can see in the picture here, we're looking at things such as physical health status, history, pre-morbid personalities and coping styles, cognitive, assessments, environments, and mental health. All those things together can cause, a person to be the way they are now. So there's always some reason behind all that things happen. So I'll go through that in a bit more detail. So we're going to examine Vera today. So this is a lady called Vera. Again, names have been changed for confidentiality purposes. So Vera is an 89-year-old lady. She lives in a nursing home and she's had increased incidences of distress and agitation. She's a diagnosis of vascular dementia and has problems with spatial awareness, orientation, and communication. She was recently admitted to hospital following a fall, and she fractured her hip and sustained bruising to her eye. She dislikes crowds and prefers her own company. So, using our Newcastle model, I reviewed this lady on the wards. She'd been back from an operation for her hip. She'd recovered from the anaesthetic at the time because I wanted to get a realistic understanding of what was going on. I wanted to make sure there was no other influencing factors. So I looked at this lady's life history. So she'd previously worked in an office. She had a daughter. Her husband died many years ago after taking steroids as part of a research trial. and she has been resistant to taking medication since this. So the staff were having a lot of problems getting her to take pain medication. And again, we needed to be really mindful of her life history. And actually, even if she had had dementia, she'd been very aware and avoidant of taking medications. Obviously, we need to consider if what's in her best interest and support her with that. But that was a part of her history that it was really important for me to know that. In terms of her physical health, she had a recent hip operation. She also had osteoporosis and arthritis, and she was a high risk of falls. So again, as we know, people who are more concerned about falling are more likely to fall, but someone in pain also has an increased risk of falls. So again, if we can't control this lady's pain, she's more likely to fall as a result. Because imagining your leg's in pain, you're not going to lift your leg the way you want to lift it to make sure that you are base trick. And someone with dementia, perhaps with her level of cognitive understanding, she's less likely to assess those particular environments. So this is one of the pain tools that you could use, and it's called the ABI pain scale. So as you can see here, there are various domains that you have to fill out, and you score it based on what you see from the person. So again, physical observations and spending time with that individual is really important to make sure that you have an accurate assessment. So in regards to Vera, our previous case study, when it came to her vocalizations, I identified that she was whimpering quite a lot. She was quite a lot groaning as well. So again, it should be at least 2 or 3. So if I give her a 3 for that one. Her facial expressions are quite tense and she was always frowning. So I'd give her a 2. Changed in body language. Again, she was quite withdrawn, but the other ones didn't really fit her. So I'd mark her a 1. In terms of behaviour changes, so we're looking at things such as increased confusions, refusing to eat, altered unusual patterns. So again, I'd give her a 1 for that because she was obviously sleepless a lot more than she used to be. Again, that's difficult to tell if that was from the pain or from the changes in environment. We're looking at physiological changes, so in terms of her blood pressure, her temperature, a colour of her skin. She was quite pale. Her blood pressure was slightly raised as well, so I'll be giving her a 2 for that one. And then physical changes. So again, she's had previous injury, so I'll be marking her as a 2 for that. And again, the arthritis as well is the condition she had. So as you can see there, she scored quite highly. And that would allow me to use this assessment to move towards medics and explain to them that this lady needs a pain and analgesia review for her pain management. So this is another pain assessment we tend to use. So it's known as PAINAD, so pain in Alzheimer's disease, but it can be used across various types of dementia. Again, it has a very similar assessment to what the ABI pain scale does. So again, it goes through breathing, independent of vocalization, so normal, occasionally laboured breathing and noisy laboured breathing. So again, it goes from 0, 1, and 2. It goes through negative vocalization, so again, occasional moanings or groans, low levels of speech with negative or disapproving qualities. It looks at things such as repeated, troubled calling out, loud moaning or groaning, and crying. It looks at things such as facial expressions. So are they sad? Are they frightened? Are they frowning? Are they grimacing as well? It looks at things such as body language. Are they rigid? Are their fists clenched, knees up to their chest? Are they pushing away? So again, are they resistant to care? Which again, we see a lot with people with dementia. But it doesn't always indicate pain, but it's something to be mindful of. And then consolability. So can we console the person? So again, can we distract them? So using what we would normally call our Vera method. So validation, emotion, reassurance, and activity. If that doesn't work, then I'll be considering that perhaps this person needs a pain review. So we're going to finish off with the final case study. So this was a gentleman I saw very recently, and it really opened my eyes to the importance of recognition of pain, especially in people living with dementia. So again, names have been changed for confidentiality purposes. So John is an 86-year-old man who lives in a nursing home. He was admitted after a fall and reduced mobility, and he was admitted to our medical assessment ward for assessment and treatment. Upon review, John is asking you to help him get out of bed and is shouting in a distressed manner. Staff keep putting him back into bed for his safety, but this doesn't seem to reduce his distress. Okay, and this is a situation I see an awful lot. Someone trying to get out of bed, trying to communicate something, and staff will support them getting back into the bed, but actually we're trying to work out why this behaviour is taking place. So, as the Admiral nurse, I came to review John. I undertook a pain assessment for this purpose. I've done both just so you can see the differences in scores. But essentially, overall, the pain assessment scores were high for John. So in the Abbey Pain Scale, he scored 15 out of 18, and for PainAd, he scored 8 out of 10. He was asking me to help get out of bed, and when I asked why, he kept saying his back. So again, staff had never questioned why. They'd never asked John why he wanted to be out of bed. Again, we can always see people with certain life histories that are very active, for example, farmers or people who have very active jobs who want to be out of bed. So I always ask because it might be there's a particular reason, they might need the toilet. Again, they're all the things I'd be asking. But again, he kept complaining with back pain. Every time he leapt forward, there was evidence of pain. So he would shout out whenever he lifted forward. He'd be grabbing onto the side rails and trying to pull himself up with them. And every time he did that, he would grimace. His facial expressions would change. And looking at his history, he had a previous fractured neck of femur, so a fractured hip, a month prior to readmission. Ever since he'd gone to the care home, his behaviour had accelerated after that hip fracture, and he'd come back into hospital as a result of a failed placement after recurring falls. So again, this gave me a lot of ideas here to think actually there's definitely some pain going on for this gentleman. So in regards to some interventions then, so for John, I referred him to our acute pain service. So we are very lucky in our hospital to have a pain team who can come and review that. So because it was acute, because it was less than 3 months, I referred him to the acute pain service for advice. And again, the analgesia that he had in place at the present time wasn't effective. So I think he was on something like paracetamol and some sort of Oromorph, but it wasn't seeming to be working for him. Distraction technique. So as I was sitting with him, I was trying to see if I could distract him to see if there was, a way of managing this. Unfortunately, non-pharmacological methods didn't work. It was only very beneficial for a short period. So speaking to him about his family, distracted him for a second before he then wanted to get straight back out of bed again. And behaviours were his way of communicating his pain. So taking the time to really sit with John to analyse his behaviours alongside the medical history gave us a really good understanding that this gentleman needed a pain review. So when it came to the outcomes, the acute pain service came to review his pain and they prescribed a pain relief patch. I think something like a buprenorphine patch which sticks onto the side of his back here and works continuously over a period of time. Once the pain was obviously controlled, his behaviours reduced. He was more mobile. So when he was he moved to another ward and was mobile around the ward, undertaking activities with our activities coordinator, and overall was much more social, much more engaged. He sat out of bed more frequently, and when he did, he was calmer. And he returned to a nursing home with much improved outcomes because they were able to manage his behaviours then. Previously they found it difficult to manage the levels of aggression and the agitation he was presenting with. And now that we identified it was his way of letting us know he was in pain, he was much more calm, and they obviously understood that when those behaviours presented, it meant that he needed more pain relief. So here are some references. As I say, there's lots of brilliant resources out there that look into pain management people with dementia. So I'll leave those there for you to do any further reading that you have. And I just want to thank you all for watching. Again, I'm here for any questions that you may have, and hope you enjoy the rest of summer school.